And we have a large number of stakeholders, private companies, NGOs, foundations, donors. And the only focus that we have is youth employment. And in particular, we like to highlight very practical solutions and innovative ideas that can help governments and the development community deal with youth unemployment. So the topic for today is actually a really interesting one. um, we know that during COVID, it was pretty clear to all of us in the countries that we work in that there was a gross underinvestment in the health workforce, and this health workforce is absolutely critical if countries are to invest in the human capital development of their country. Now, while we say this in one breath, in another breath, we also say for those very countries that there is a huge youth unemployment challenge. So, what if you put both these development challenges together and ask yourselves like a simple question, why can we not think about opportunities in the health sector which might provide interesting ways for youth to get access to good quality jobs while at the same time strengthening the health ecosystem of that country? Um, and I guess the question is a simple one, right? But the countries we work in, actually in a lot of areas, we find that sometimes the Ministry of Labor simply is not talking to the Ministry of Health. Sometimes it's as simple as that. um, and so we recently published a discussion note where we asked ourselves this question: what if we were to find these win-win opportunities? And we particularly highlighted three subsectors in the health sector where we said this could provide opportunities for entry-level positions, perhaps. And the three subsectors we highlighted were non-technical support roles in the health sector. So these are not qualified health workers, but are really critical to supporting the health workers. So like orderlies, like nursing assistants, perhaps, or people who work in the administration side of health. The second subsector we highlighted was the care economy, which you know is particularly important, also to address low levels of female labor force participation, because women tend to handle most of the care responsibilities. And the third, which is the topic for today's discussion, is digital health. And this is kind of a big subject because it can help with all of this new technology, it can help increase access to health. Um, Also, with all of the wearable devices that are coming in, we have large amounts of data that, if fed back into the health system, could help us really strengthen preventive health. So, what are these new ideas? What might be ways we can think about these subsectors as ways to address both the health sector as well as youth unemployment? So, we have a really wonderful panel today, and I'm going to hand it over to them. Um, I just want to quickly introduce them. Charles Dalton, who is Senior Health Specialist at the IFC. I guess you all know, but particularly for our partners, that IFC is the part of the World Bank group that particularly focuses on private sector. We have Kate Tulenko, who is founder and CEO of Appleseed Education. It's an ed tech platform, and she'll share more about it during her comments. And Tegan Palmer, who works with UNICEF, which has developed a very interesting app. I'm not going to tell you anything about it. She will share that with us. So before I hand it over, before I invite Charles to sort of kick it off, I'm going to have my colleague Urvashi just share some very quick highlights of the recent discussion note that we published. In this discussion note, you might have already seen it. We asked ourselves this question about these win-win opportunities. So maybe over to you, Urvashi, just to provide some sort of quick framing comments so that we can then get into the discussion. So over to you, Urvashi. And I'll have a look at my camera again and why it's not working.
Absolutely. Thank you so much, Namita. Really looking forward to the rich discussion today. I'm going to quickly start off with some high-level points on the discussion note and then hand over to our panelists. Um, so we think that there is a clear need to invest in the health workforce and to create a productive and quality health workforce. This has been heightened by the COVID-19 pandemic. It's been heightened by rising living standards as well as longer lifespans and new technology. Particularly in low and lower middle income countries, investing in health is a critical pathway to socio-economic recovery. This is also echoed in government's budgetary expenditure or the priority they allocate to health, which is growing faster than the rest of the global economy at more than 10% of global GDP, as you can see with the upward trajectories on the graph on the right. In response to COVID-19 as well, the median increase in health spending in low-income countries was 55%. And we see this as an opportunity which could potentially create millions of jobs. There are, however, three key challenges that the health sector currently faces, which we think policymakers, TVET skilling, and youth employment initiatives must take note of. The first challenge, 76 countries have less than one physician per 1,000 people. This translates into 3 billion people who don't have access to a health professional. In addition to this, by 2030, the projected health workforce shortage will be 15 million workers. Based on need estimates, there is potential to create 40 million health jobs globally. If you observe the red lines in the graphs on the left, the largest needs-based shortage of health workers lies in sub-Saharan Africa and South Asia, and this is forecast to worsen by 2030. So there is a critical need to address both the health workforce supply shortages, such as underinvestment in technically training workers, but also stimulate demand for health services to address this shortage. The second challenge that we discover is that of gender equity in the health workforce. 70% of the health workforce is women, particularly those in the care economy. They're concentrated in lower paid roles and they're underrepresented in leadership, as you can see towards the top of the graph on the right, on the left. While women in health contribute 5% to global GDP annually, 50% of their contributions are unrecognized, unpaid, and outside the formal labor market. We think this is a problem that needs to be addressed as well. In terms of the final challenge, which is the topic of today's discussion, this is related to the digitization of the health workforce. There have been many emerging jobs due to this digital transformation of healthcare, which include mobile health tools, medical wearable devices like Fitbit, augmented reality or virtual reality for surgery, personalized healthcare, etc. And these new jobs, they require new digital skills. Surveys say that lack of skills have proved to be a major barrier for this digital transformation of healthcare work. So we think that the challenges faced by the health sector, as well as the urgent need to make up for this 15 million health worker shortage, presents a significant opportunity for 64 million unemployed youth globally. Vocational training and youth employment initiatives from government, from the private sector, they must capitalize on this dual opportunity to prepare and employ young people for meaningful work in the health sector. There are three key areas that we highlight in our note that may be capitalized upon. The first opportunity is non-clinical supporting health jobs. Non-health jobs like orderlies, home health aides, patient care techs constitute 60% of all formal health jobs globally. Given that each health worker is supported by 2.3 non-clinical health workers, there is an estimated need for 57 million more jobs for non-clinical health workers. Young people can be trained through flexible short-term courses to be employed in such roles. The next opportunity lies in emerging healthcare technologies, which are booming. Here are some statistics. 76% of healthcare consumers are moderately likely to use telehealth in the future, which has increased due to the pandemic. 47% of healthcare organizations use predictive data analytics. There are 440 million consumer wearables which are set to ship out globally by the year 2024. The medical virtual reality market will be 5.1 billion large by 2025, and the women's health tech market will double that and reach 9.4 billion by 2024. So clearly, jobs and skill training relating to the monitoring, maintenance, and end-to-end delivery of tech-enabled health services will be critical to their use and continued sustainability. And finally, we have care economy jobs, which are set to grow in coming years. Some of the top skills demanded of care economy jobs are given in the graph on the right, and they include a lot of digital skills that young workers need to be trained in to prepare themselves for these job opportunities. Investing in the care economy would benefit not just the caretakers of 40% of all children, which is nearly 350 million children below primary school age who do not have adequate access to quality childcare services. It would also have significant knock-on benefits for female labor force participation. Since women shoulder more unpaid care work than men and are the primary caregivers for both children and aging relatives, lack of affordable childcare prevents them from participating in the labor market. A robust care economy will thus increase their workforce participation, allow businesses and economies to benefit from an expanded talent pool. Our discussion note also details key recommendations to address these challenges faced by the health workforce and capitalize on these three opportunities. We think that TVET systems could help address gaps in the health workforce through shorter term courses as alternatives to four-year tertiary education. They may yield marketable health workforce skills in less time and at a lower cost. And being more flexible, they could rapidly change, in response to evolving labor market changes. Additionally, we think that migration of high-skilled health workers to the developed world also creates tensions for low-income countries to improve their healthcare. And so we think a well-managed health workforce migration strategy, which enables capacity systems, building of health systems in both the receiving as well as sending countries, is critical. And finally, reskilling and upskilling certification programs must be added as programmatic components to training interventions in response to these changing and digitized market demands. We also believe that establishing the right linkages with industry through exposure to industry, through apprenticeships, through counseling initiatives is the need of the hour to enable such health workforce partnerships and to enable young people to enter the health workforce. Thank you. Over to you, Namita.
Thanks a lot, Urvashi. I think that was a really nice sort of laying out of the issues and the opportunities. So without any further delay, maybe hand it over to our first panelist, Charles. Charles, over to you.
Hopefully you can hear me. Good. Okay.
Yes.
Thank you very much for the opportunity to speak today. So I'm going to just explain from my perspective and the IFC perspective where we sort of see digital health jobs for sort of youth coming from in the future. I'm not going to repeat what's already been said, but healthcare as a sector is key for development from multiple perspectives. But I think what I want to emphasize is this potential to create 40 million new jobs by 2035. We have this massive shortage, which I'll touch on as well. Plus, we've got this digitization of the healthcare sector coming. It's been with us for a while, but COVID has created this light bulb moment where all of a sudden we're seeing far more interest and focus and understanding of digital. And we're also now seeing digital being built into public and private healthcare systems. So that's really where I'm going to be talking from today. And just to sort of recap here, what we're seeing globally is health trends are changing. So disease patterns, we're getting an elderly population. We are going to have a legacy impact of sort of COVID on these healthcare systems. The changing disease profile requires new ways of care and new potential opportunity when implemented correctly for new technology in many or most markets. And we're also seeing a growing role for the private sector as well to be able to work with governments, and particularly on digitization. This is very relevant because it's the private sector that's often developing these digital these digital tools and to support the governments to do this digital enablement. And so what I also wanted to emphasize at the bottom here is this healthcare worker shortage. So it's already been touched on in the excellent introductory presentation. And research varies, and I think it depends on where you come from, on the way you calculate the research. So I found one here that's putting the estimated shortage on healthcare workers alone at 43 million. And that includes the nurses, the midwives, and the physicians. And the idea is really saying how many workers do you require to get you to that point where UHC can be delivered successfully. So universal healthcare delivery in most countries is not really attainable at the moment because they don't have the resources and the workforce to be able to do that. So when we're looking at this, we need to look at traditional workforce, plus we need to look at the workforce that's coming from the sort of the digitization as well, because we're not going to train enough quick enough on the traditional. So we need to look at how digital can enhance service delivery when it's planned and implemented correctly. And I say that a lot. So digital disruption in healthcare is going to create new job types. So one, the existing workers in healthcare are going to have to be digitized, i.e. they're going to need to understand how to use digital, and that in itself has been problematic over the years. So for example, the use of hospital information management systems, a lot of healthcare professionals aren't trained, no change management, so they don't really understand why they've got to do it. So there's that component, plus what you're going to see as we go through the presentation is the need for new digital jobs. So what we've really seen, is the light bulb moment that COVID has helped in some ways. Consumers and professionals seem to be more open to using digital technology in whatever form. We know when it's implemented correctly, it can lead to efficiency. It can lead to better skills sharing. It can lead to better access to treatment and care. But also healthcare providers, governments, private sector, they need support and help in how to do that. So very quickly, when I'm talking about digital, it cuts across the business management side of healthcare, i.e., financial management, human capital, procurement. It also touches on the clinical staff and management, the electronic patient record, knowledge exchange. So how do I get knowledge to a nurse in a remote location if I'm sitting at a central hospital? So again, that's where digital has a big role to play. Patient services, so how do I engage with the patient? How do I share information? How do I give the patient education? So again, good examples of how digital can be used. And then care innovation, so that extreme side and the real technical scientific side of digital is home digital therapeutics, in-home care services that supplement traditional, the telehealth that we've all seen emerge over the last couple of years. What I want to do quickly is just walk you through a case study that we did in Mexico with one of our clients. So it's a diabetes provider with clinics. They serve 11,000 patients per month. They focus on diabetes and hypertension. And we did a study with them to sort of help them understand how digital could help them expand their geographical footprint, improve patient results, and reduce operating costs. And there is an actual separate case study which actually can be shared on this. So if we look at this from a digital touch point perspective, there's the video consultation, there's the electronic prescription, so no paper, you can do a prescription electronically. You can send messages, reminders to the patients, reminding them to do certain things to manage diabetes. The key with diabetes is to get the patients to do the right thing at the right time. So you can actually engage with them remotely through basic SMSing to saying, have you done A, have you done B, have you done C? On the financial side, you can do whole electronic statements, payments, renewals, and contracts. So you can work with insurers, you can work with cash payers. So it doesn't need to be a paper process, which leads to that efficiency. Sorry, I nearly said inefficiency. You then got the e-commerce. So how do I, as the clinic, buy my drugs, buy my supplies. That doesn't need to be a paper process. That can be all done electronically, and that in itself leads to efficiency. Sort of the lab studies, we're seeing the advancement of digital health within lab as well, in terms of collection, anticipating, sort of using AI to look at results. You've got the simple and digital access. So looking at it from a simple perspective, saying, okay, what's my digital competency? What processes do I need to realign to that digital competency? And how do I work with my people on that digital competency? And that's important when you're looking at digital health. A lot of people fall into the trap. Governments, private sector, oh, I have this solution. I'm going to plug it in. It's going to fix all my problems. I can guarantee it won't. So the solution is probably 20% part of the digital health is probably 20% part of the solution. There's a massive process and there's a massive people element to it as well. And if you take one of those out, you're not going to get the benefits that you think. So digitization comes from multi-perspective as well. And then also we see on the top left-hand corner here the member app. So how do I engage with the member? So, you know, in terms of their medicines, booking appointments, speaking to somebody online, and then education as well. So as you can see from this diabetes center in Mexico, multiple digital touch points which can enhance the business. So what they did is, and this was a pilot, is really looking at how an app in a phased approach can help them engage with that clientele and improve the efficiency and those touch points. So on phase one was the appointments, looking at rewards. So rewards, diabetes, you've got to manage it actively. So how do you reward that patient actively for doing the right thing at the right time? And we're seeing that in other markets. So we've seen payers in some market adopt reward mentality for those with chronic diseases, saying we will reward you if you do the right things to manage your health. Again, all digitized. Video consultations was the second phase, scheduling, cancelling, rescheduling statements and accounts. And then the third phase was looking at the risk calculator, reminders, e-commerce, membership renewal, the gamification, rewards, nutrition. So what they do with this diabetes, they're managing it from A to Z. So they're looking at you from what's wrong, your status of diabetes, give you access to a pharmacist, access to a pharmacist, access to a dietitian, access to a nurse, access to also supplies needed to manage your diabetes as well. So hopefully through this very quick insight, I've been able to touch on many of the different aspects of digitization. And my last slide really focuses on, it's not just the traditional healthcare professionals now to make a health system work going forward. Yes, we need them. We haven't got enough, and there's careers for everybody if you want to do that, and we need that. But what we're also seeing is with this digitization, there's a new cadre of staff and a new cadre of staff where there's opportunity from a youth perspective to start looking at the healthcare sector differently. We need software engineers that understand health, but then can develop the right solution. We need coding clerks. Okay, what's the best use of a doctor's time? It's not to fill out a piece of paper. You can actually have people to do that for you, and the sort of the coding, to get the coding right so the data entry is correct. We have data analysts, we'll have web designers, we have product managers, there'll be call center agents who are using that digital technology as well. So as you see, the word engineer comes up a couple of times, AI, machine learning. So the extreme side of digital is this AI learning. So this capability to replace human assessment with AI assessment. We're getting there, still a long way to go, but huge potential. So again, data scientists, data security analysts, I think you're getting the point. Information management as well, and trainers. We're going to need a lot of people to train the existing professionals on digitization, but also take this new cadre as well. What does healthcare mean? What does it need from a digital perspective? How do you implement it? So I think you can see that we're seeing this gradual extension and broadening out of the careers that will be required within all health sector globally from now on. So thank you very much, and I'll hand back. Thank you.
Thanks a lot, Charles. I think that really made it come alive. Like I really like that example of the the diabetes case study in Mexico, because it kind of made it come to life that it's not just at the final sort of last mile delivery of health services between the doctor and the patient, but it's sort of down the value chain. It's how we do our billing, it's how we do our maintenance of our medical records, and so there's a question of new skills, but there's also a question of upskilling people who may have some what you call traditional skills. I really enjoyed your presentation. And I just want to encourage everyone that let's keep this fairly informal. And so if you had any thoughts or comments or reflections to what you just heard from Charles, just please do put it in the chat box, and we'll come to it towards the end. So with that, I'll hand it over now to Kate. Kate, you're with us, right? Kate, over to you.
Yes, I'm here. Yeah, can you hear me? Hi, I'm Dr. Kate Telenko, and I'm the CEO of Corvus Health, which is a global health workforce firm. We work with governments and private health systems to train new health workers and to optimize their current teams, both from a care and efficiency perspective, and also to help retain them as well. And so we're going to talk about digital health opportunities to empower youth and look at it from a labor market perspective. And Charles' talk was a perfect introduction, as he mentioned the fact that there's both the new jobs and then also integrating digital into the existing healthcare jobs. Next slide, please. So first, we're going to briefly introduce the labor market model, so you understand that governments and also the private sector have to act across the entire labor market if they're going to introduce these new digital health jobs and get youth effectively employed in them. Then we're going to go over some best practices from our experience, and then some common mistakes that are made in labor markets that, if these mistakes are made, will make it very difficult to introduce these new jobs and get youth into them. Next slide, please. So this is a very busy slide, but it's the labor market model that's shared by the World Bank and WHO. And the important part to note here is that the orange part is in the education sector, both high school, TVET, and college. And then the blue part is both the public and the private health sector, employment and also self-employment. And that government needs to regulate both parts of these, needs to have financing, needs to have effective policies in both the education and throughout the life cycle of the employment. And so we'll talk more about these different steps as we go along. Next slide. So we'll jump into the best practices. One of the most important parts of making policy is having data and doing research. And so an example that I'm going to give is that you need to determine employers and communities' current and future health workforce needs, so that you train to meet the employment needs. I consider it unethical to train people for jobs that don't exist. And just to give an example from Somalia, we were recently helping them with their new health workforce regulation, and they did not have a complete listing of all the health professional schools. And so that's one thing that we helped them with, because once they had the data on all the schools, their locations, the programs they had, how many people they graduated per year, they could then plan on how to help them expand, what new programs needed to be added. So you need that data to make those decisions. You need to ask hospitals, how many coders do you need? How many server managers do you need? And then work on building the programs to educate those employees. And then for planning policy, for planning policy and regulation, an important part is team redesign and the creation of new professions and creation of new career paths. It's not just enough to create a single profession, because people are often unwilling to go into it because they see it as a dead-end job. You need to show the entire arc of the career path, that how they will advance and what will motivate them to do well, so that they can become, first a coder and then a biller, and then, go into server management, and then you need to show that career path. And in many governments, they actually need to create and professionalize these jobs. This was an experience that we learned out of HIV/AIDS when we were introducing social work AIDS, because social workers in most countries are a master's level position, which is just not feasible in many countries. And so a social worker aide, we envisioned as someone who had 6 months or a year of education on case management. And you have to go through the whole process of starting these new professions and creating that career path. And on a team redesign point of view, we have to get outside of this traditional nurse physician model. And as Charles pointed out, when you enter digital, into the health sector, it really changes everyone's jobs, and actually you end up redesigning a lot of different jobs and what people spend their time doing. Next slide. So from the point of view of education in high schools, it's so important to have career counseling. People cannot pursue jobs they're not aware of. They cannot pursue education for jobs they've never heard of. So it's important that you have public education, that you have career counselors at the school level, that you produce pipeline programs. A lot of the digital health jobs, actually the skills can be taught in high school, especially with this new badge approach that, that what Microsoft and Google and others have developed, is that there's certain jobs you can do with 6 months training. You don't need a bachelor. So there's no reason why that can't be delivered at the high school level. And the example I'm going to give here is Tennessee has an incredible career, pipeline program to get minorities into healthcare jobs. That they reach down to the high school level, to, starting with the 9th grade, of getting people interested, educating them on the hundreds of different jobs in the health sector. Most people just know doctor, nurse, and that's it. So that's an example of what we need to do at the high school level. Then at the health professional school level, you need to establish the new health IT programs. For example, I was previously part of a group that developed the most commonly used HR program for health workers. And we knew that we couldn't just always fly in to do the training. We had to establish a training program at a local college so it would be sustainable. So that's an example of how you have to establish these sustainable educational programs. You also need to integrate health IT content into existing programs for pharmacists, doctors, nurses, hospital managers. And for this, we had created a digital health module that you could insert in pretty much any curriculum to help them understand the new role that digital was playing in health. And then very importantly, you need to align public education funding with open jobs and market projections. For example, we find a lot of people, studying classics or history when there's not jobs in that area. Then on the other hand, there'll be millions of open nursing positions, but the nursing school can't expand for want of money. The state of South Carolina in the US has aligned their public higher education funds with open jobs in the state, which I think is a brilliant idea. And once again, I think it's unethical to train people for jobs that don't exist. Then you also need to align your regulatory caps with open jobs and market projections. Healthcare education is the most highly regulated education field, and especially in low and middle income countries, they're under severe caps. And so you'll have schools under caps at the same time that you have thousands of open positions in that country. And so we really need to take a good look at that. And I use the example here of Ethiopia, which constantly reaches out to both public and private facilities to see what the demand is, and then adjusting the caps to meet that need. Next slide. And then, employment and self-employment. We need to create continuing professional development and in-service training for digital health workers. This is, most of the workers working now, of course, have done their pre-service education. So we have to upskill them with these digital skills. And the example I'm using here is our IRIS update courses. These are courses to help health workers understand, how to use this particular system. And then the final example I'm going to use here is migration. There's been a lot of talk about mobility, whether it's regional. For example, East Africa is now regulating health workers regionally, or whether it's globally. We're going to see a lot of movement of health workers from the global south to the global north, as the global north ages, has a lot of elderly who need care, and they don't have the young people to fill those jobs. So if we want this type of mobility, we need to standardize the professions and standardize the certificates. For example, one thing we're working on is a global elder care certificate that can be recognized globally. And in the IT sector, Google has this IT support certificate that is, recognized globally. And of course, Google as a global brand, people recognize that. Next slide. So we're going to do common mistakes. The first is that you see again and again when people are doing digital transformation, they buy the servers, they buy the machines, but they forget about the people. So you have to remember that the people are the most important thing, that make the health system work. And the examples, I'll give here is all this talk now of investing in African pharmaceutical and vaccine development or production, but no one is looking at what is the capacity to train these very high skilled workers that you need to develop vaccines and that you need to manufacture vaccines and pharmaceuticals. It's not community pharmacists and it's not bachelor's level chemists. These are extremely skilled workers. And so we need to develop the pipeline to educate these people in Africa, and probably just maybe a francophone, Lusophone and Anglophone node would be enough, just one or two schools. And then also we see this in cancer care, people buying all the linear accelerators that you can, but there's not an oncologist or there's not a tech to manage the machine. Another common mistake we see is, once again, not planning out that career path. People don't want to enter what they perceive as dead-end jobs. You need to show them the promise of this career path and that, how they will step up in their career with good performance. Another common mistake is not professionalizing them, defining the cadre, putting them in the regulation, helping them set up an association, giving them continuing professional development, making them, a respected, recognized professional. And then another common error is not financing the entire labor market. So you have to finance, the STEM education in high school or the TVET in high school. You have to finance the college level or the college level TVET. And of course, you need to, create the budget space to hire the people in these fields. Health IT is going to change a lot of different costs, and it's also going to drive efficiencies. But often in the meantime, we need to adjust our budgets, and that's quite often not done. And I would say, I think the number one mistake that I see in introducing new types of health workers, especially digital health workers, is not creating those pipeline programs. Once again, you can't pursue an education, you can't pursue a job if you've never heard of it, you don't know how much it pays, and you don't know what the career promise is. So thank you so much.
Thank you, Kate. That was really excellent. It brought up quite a few issues. And I want to, I have a couple questions I'd love to ask you. I hope we have time in the end for a lot of discussion. But before we open it up, I just want to go to Tegan Palmer from UNICEF. Maybe over to you.
Hi, thanks so much for having me. I'm just going to share my screen and make sure you guys can see it and you can hear me. Wonderful. So my name's Tegan Palmer. I'm the Monitoring, Evaluation and Learning Specialist for OCCI. OCCI is UNICEF's flagship period tracking app, which is launched around the world with girls to help them understand better menstrual health, sexual health. And it hasn't been designed as a youth employment solution, but I'm going to tell you a bit about OCCI today and how it might link into the topics we're talking about, as well as sharing a few learnings from deploying digital solutions in the health sector. And although OCCI is a health tech app, within UNICEF, it usually sits within the WASH, so water and sanitation, or gender or education kind of brackets, rather than health. And obviously, as a UNICEF app, we focus on children and youth. So OCCI is aimed at girls aged 10 to 19, but OCCI is for everyone, for urban, rural girls, boys, for the communities around girls. And the idea is to contribute to destigmatizing menstruation and girls' sexual health. And I guess that takes us back to the problem statement, which is that around half the world will experience menstruation, but it's still a taboo and still a stigmatized subject for many people around the world. Many girls have little or no preparation for menstruation. Many feel unprepared for it to start, and this leads to things like girls missing school. There's a couple of stats for you on the slide here, but this is really a global problem. that girls miss school during their periods, and it leads to a gender inequality in the quality of their education. And this kind of fits into the framework that Kate showed on the previous slide, and how Oki, I think, best fits into the discussion today is as a potential tool to help girls to have an improved education, both through not missing school due to menstruation, and also due to sexual education, allowing them to make potentially different choices, avoid unwanted pregnancies, and continue to finish education rather than leaving school early and being able to join any form of formal labour market, including in the health sector. And there is already sex education and menstrual health education in schools, but it's usually kind of top down, it's paper based, it's taught by teachers or other adults who might not be trained in these areas. And sometimes we find that it exacerbates the stigmas around menstruation rather than improving them. So the UNICEF team stepped out and went to ask girls what they wanted. What did they need to know that would help them? How did they want to learn it? And a user-centered design process and co-creation happened in many countries around the world, including Indonesia, Mongolia, and the Philippines, where more than 600 girls were consulted, and so were their parents and boys in their communities, religious leaders, to help us to come up with the Oki program. And girls determined things like the look and feel. They determined that they wanted a digital solution, that they wanted an app, and what the features needed to look like to help in order for it to help them. Oki is now live or being localized in around 13 countries around the world. So the numbers on this slide underestimate it a little, how many girls have been involved in this process. And what they told us they wanted was a smartphone-based solution, which was fun and attractive, and it includes a calendar and a cycle tracker, and it's full of information from experts around the topics of periods, the body's relationships, puberty, and the information included has been designed with and for girls too. So although it's written by experts, it's communicated in very girl-friendly language. It answers the questions that they most want to know about, and it does so in a very kind of loving, empowering tone of voice, because girls told us they wanted Oki to be more like a big sister than a doctor, someone who can answer their questions without kind of judging or feeling medicalized. The global Oki app was launched in 2020, and now we've launched it in 4 more countries. As I said, many countries are waiting to launch, but I guess it's only been a few years. It's still very early days for Oki. We're very much still in the phase of learning how best to deploy and scale something like this. But I'm just going to tell you a few things we've learned through the process of talking to girls and building something digital for them. So Oki is built to meet girls where they are in terms of digital realities around the world. Many of the girls we spoke to had lower end phones, so Oki is a super lightweight app. They had limited connectivity or couldn't afford to pay for data. So Oki works fully offline. It's once you've downloaded Oki, which can also be done offline in the right circumstances, it works fully on your phone. So there's no need to connect to any servers or anything like that to enjoy Oki. For girls with lower literacy or lower digital literacy, Oki's been designed to be super easy to navigate. There are tutorials to take you through. There's a text-to-speech function, which is useful for people with lower traditional literacy, and also girls with certain disabilities, with whom we're also testing the app and making sure it helps them. And it's then promoted in various ways, one of them which is through social media that helps us to reach more tech-savvy people who are already kind of online. But there's also a huge community of organizations around the app who are helping to roll it out and take it around the countries where it's launching, to sensitize girls and their communities to the topic, but also to the use of a technical of a digital tool. And so we've done things like there's a school-based program, of course, but there's also events like medics going around in an ambulance and stopping in central squares to talk to people about girl sexual health, about menstruation, and kind of break down the stigmas that way. Some of the regions have also trialed the same approach with people like stand-up comedians to kind of break down those stigmas that exist, while also kind of educating. And then there's also obviously a schools-based program to reach out to teachers. So Oki is also part of the curriculum in many countries, in many of the countries we're working in. So now teachers can kind of draw on it through the ministry level resources. But as well as that, you know, we're still learning what works in different countries. But Indonesia is our furthest ahead so far, and there we're piloting also a peer-to-peer program, so girls can train each other to use Oki, and that program includes a certain amount of digital skills training, because Oki is for all girls, and some girls we work with already have these skills, and the younger generation are kind of have grown up with this being part of the world since they were born. So it's a great generation to target if you're looking at something like a digital tool. But there is some training involved for people who haven't had so much exposure, because we don't want to exacerbate those divides between those who do have those skills and those who don't have them yet. And for the same reason, we're also developing low-tech platforms for Oki in various countries we're working in, like interactive voice response, so you can call and access a phone menu, or radio in Papua New Guinea, for example, where smartphone penetration is very low outside of urban centres. And all of this will help to sensitize girls and their communities to Oki, and eventually also contribute to reduce stigma around menstruation, we hope, allowing girls to experience normalcy in adolescence and potentially allowing them to better contribute to a workforce. We also hypothesize that as Oki is a rare product being designed with and for girls, it will also provide a relevant use case for girls to practice their digital skills and grow their digital literacy. And we hope to build on this part of this element of Oki in the future. We're starting to talk about working with girls on the Oki code itself through things like hackathons, to kind of bring more girls into the tech workforce as well. There will be so many digital tools which will be aimed at youth services, and I'm sure some people on this call are thinking about or already experiencing these kinds of tools. I'm sure they're changing the face of youth employment like everything else. But if you are thinking about deploying a digital product for youth, I would recommend first and foremost that you talk to them, you ask them what they want and need, how they want to use it. Talk to girls, talk to boys, talk to people in rural and urban areas, talk to children with disabilities. Don't assume that something which works in one context will always work in another. And yeah, I guess the other thing is that Oki is not just an app, it's a whole program of people that kind of surround this digital product. So yeah, a digital solution on its own, I think, is never going to be, or rarely going to be, the answer. The team that created Oki, including myself, have developed this set of tools which are focused on how to do some of these things and how to kind of co-create solutions. They're focused on girls because there's a lot of inequality, as I mentioned already, in the tech sector, but they can be applied to any audience. And there's a link on this slide, but you can also follow that link. You can also find them if you Google UNICEF gender tools. If you want to find out more about Oki, you can do so on our website, which is okiapp.info. Please feel free to reach out and contact with me with any questions. But now I'll hand back over to Namita.
Thank you so much, Tegan. I really enjoyed that. And I think it sort of emphasized not just the what to do, which, you know, sounds like a no-brainer, isn't it? I mean, it's just such a simple thing, like just developing that product. And it just struck me how, you know, in a lot of the work that we've been looking at on digital skills and training modules, the question about, you know, being sensitive to how you are designing some of these digital tools, and making it sort of relatable to the audience, is just so important. So thank you for sharing that. I also have a couple of questions, but I first want to go to the questions in the chat box, and I think just read them out. And I think probably the first question is for you, Charles. It's from Mark. And Mark is asking, what commercially sustainable assessment training, certification, and placement models that exist at scale, and how, I mean, I guess what's the commercial model that we can think of, I think, is Mark's question. And then Diana has another really interesting question. And she says it's a solution for qualified health staff that prefer staying in urban areas. It's probably what the future is going to be globally, but in countries like Africa where there's a low health expenditure per capita. So I guess the whole question about the cost per capita, maybe this is a question for you, Kate. And then I mean, one of the things that struck me when I was listening to you, Kate, was this whole issue of balancing demand with supply and supply with demand, right? I mean, you can invest all you want in creating a whole set of skill development courses on health and digital health, but if your country doesn't is not demanding that skill, uh, then you are just not going to solve the health problem. And related to that is the question about maybe should we be thinking about global markets instead of trying to balance demand and supply at the country level? But that can be potentially very tricky, isn't it? I mean, I know that in India there is this big debate about how much the government subsidizes investing in the medical colleges and training all of these fancy doctors, and only to have those doctors then migrate to the US, right? Or Europe. And so the country always feels like it doesn't get the returns to its investment in developing skilled health workforce. So there's a flip side to this whole mobility question, and I was wondering if you have thoughts on that. But then I want to turn it back to the panel. Any reactions on some of these really good questions that are there in the chat box? I don't know whether you want to go first. Who wants to go first? Maybe Charles?
I'll just quickly respond to Mark's question. It's a really good question, and I think from my perspective, if this is a space that we as IFC are trying to get our heads around now in a big way. I'm speaking from the health sector perspective. We also have an education team as well, and sort of the question there about the training, the certification, different types of training. We're beginning to see a realization in the markets that we look at. I think we are seeing more awareness in the more developed markets. So, for example, I know in the UK, the government has been very, very heavily pushing apprenticeship programs, which went away. So when I was growing up in the UK, the apprenticeship programs were going out, but they've now brought them back. So the government now is incentivizing through sort of incentiveship in apprenticeship type programs. I think in the healthcare sector, I think in our markets, it's still very, very much in its nuance and infancy, and it's something we definitely need to look at. We need to promote it with, as you say there, with employers. I think one of the problems we have in the healthcare sector is unfortunately the professional bodies. They control, like it or not, they control how many come out. They don't coordinate well with the education sector or the healthcare sector, and they're very slow to change. So if we want to create these new types of jobs and this new type of thinking and embed it into the healthcare sector, we also need to get on board the traditional professional bodies, because we need them to promote the change as well. And unfortunately, they haven't been up until now very good at doing that. So yeah, so we're looking at it. There is opportunity, but it's going to take a lot of knocking of heads to get it to move forward. Thanks.
Hmm. And then I guess, Charles, also, it's not just about involving those professional bodies, but infusing them and making them realize that it's not just the doctors and nurses, but the software engineers that are part of their community now.
Yep, it
So
is.
just the definition of that professional body also needs to change, no? I mean,
Yeah, it is.
mm,
And I think Kate touched on it as well. I mean, it's career pathways, and we need to open people's eyes so they understand that the healthcare sector, I think, is one of the biggest sectors globally with the most employing the most people. And we don't really promote that career pathway. So if you ask the average schooler, and Kate said it, they talk about a doctor and a nurse, but there's hundreds of other jobs where you can build a career for yourself from university or not going to university right the way through to retirement, but we don't coordinate, we don't promote. So we need to change that mindset. It's difficult to do, but I think digital will hold that opportunity, because as we see digital health becoming more prevalent, we are going to be seeing people suddenly thinking, oh, I can build a career in doing this, and I can
mhm,
stay within the sector. Again, not easy, but I think it'll come. Thanks.
mm. Kate?
Yes, well, thank you for all the wonderful questions. On the question of sustainable training certifications, I mean, most of those tend to be driven by the software companies themselves, by Cerner, by Microsoft, by Google. This is where I think the health sector differs from other sectors, or I would just say the IT sector differs from other sectors. If you look at traditional trades, you know, an electrician's an electrician, but if you're going to train someone to work on an electronic medical record, you know, they're very different from each other. You know, training on the Cerner model will be very different from training on another model. So a lot of these are going to continue to be software driven and driven by those software companies. And on the question of maldistribution, so we have a huge challenge globally in both high income and low income countries between a complete mismatch between where the unmet health need is and where the health workers are. All the health workers are in major metropolitan areas and all the need is in rural and remote areas. I do think that digital health will help bridge this gap. But that definitely is something that we need to work on, certainly getting the youth employed in that. And, you know, on the issue of the unions and the self-regulation that goes on, it is indeed a huge challenge. You will have, you know, some areas where they don't want new professions to come in because they see those professions as a threat. And that definitely is something that that needs to be addressed. But I think also people in the IT sector need to watch their language. I've had a lot of people come to me and say, you know, we don't need more health workers. We're going to put you all out of business. We're going to replace all your health workers. It's just very, you know, it's just very aggressive, and it's not a way to sort of make friends in an industry. You know, instead, health workers need to be approached, you know, like Aki approached the girls and said, you know, what are your pain points in your job? What makes you want to leave nursing? What makes you want to leave medicine? Most physicians want to leave medicine now because of the EMRs. They're terrible. They've taken a wonderful job and made it into staring at a computer screen all day. The average American physician looks at their computer longer than they look at their patient. That's why I love scribes, who, you know, are the digital enters for the physicians. And actually, they have been shown to improve patient satisfaction, improve physician career satisfaction, and improve the quality of the data that's entered.
Can I just pick up on that? And that last point Kate's raised, it's a really fascinating point, because if you look at how much it costs to employ a doctor and run a doctor, and you're asking that doctor to fill in forms, but you could actually employ somebody who costs a lot less, will give you more value. We need to get people to understand what people do and what's driving their time and what's costing and what's not needed in their job. So Kate's point there is a really, really good example. Doctors shouldn't be coding. You can employ somebody at a lot less that can be a coder, and you get more value out of your doctor. This mindset is we need to change. Thanks.
Exactly, Charles. That's what I was trying to get at when I said you need to change your budgets, because people are saying, well, I'm already paying this physician $100,000. I don't want to hire a scribe for $20,000, but you don't understand, unless you hire that scribe, you're going to lose that physician. And in the end, the physician will be more productive for that $20, $200,000 investment. And probably in the end, we're going to move to AI scribes, digital scribes, but we have a while to go before we're completely there.
And there's something to be said about actually a face-to-face interaction with your doctor. I was just thinking, listening to you, that somehow, while, you know, during COVID, it was great to be able to talk to your doctor on Zoom, that there's something about not digitizing some bit of the health profession. But anyway, I think this was a really fascinating conversation, and I see that there were a couple more questions that came in, but we've run out of time. But I just wanted to also share with you all that we've only scratched the surface today, and I'm so delighted that all the three presenters. I mean, all of you raised some really, really insightful points, and we kind of just scratched the surface. And so we're going to continue this with a series back in January. So we'll be back. We're also trying to explore the other subsectors. Today, we focused a lot more on the digital side of things, but there's a lot more that we need to understand about the care economy, about the non-health support roles, and what's happening there. We touched on it a little bit today, but we'll be back in January with a couple more sessions like this. And if you have some suggestions of other themes that we need to dig into, please let us know, because we can just co-design these kind of discussions with you all. And I just wanted to say today's presentations and the recording of today's webinar will be on our website.